Hello. Today I'd like to talk to you about two papers about the treatment of COVID-19 with chloroquine, azithromycin, and zinc. Um, I'll talk about the papers in the order in which they were published. And the first one published was called, as you can see on the screen here, hydroxychloroquine and azithromycin plus zinc versus hydroxychloroquine and azithromycin alone. So the control variable there is whether or not zinc is in the mix. So this is a retrospective study, which means they couldn't have control over the study details in terms of how the treatments and that sort of thing, but they had access to the information from medical databases. So one of the things I like to do with retrospective studies, namely they're backwards looking, not forward looking, is to actually look at the papers backwards as well. So from the backwards forward, you'll see why in a bit. So let's go to the part where they tell you about some of the caveats of the paper. And I like to look at that. I like to know right away what some of the issues of the paper. So it says right here near the bottom, this study has several limitations. First, this was an observational retrospective analysis that could be impacted by confounding variables. That's often the case in retrospective studies because the study wasn't a trial where you can design the study carefully to eliminate confounding factors. When you're looking at existing data for something that was done to cure the patients, not to have a study, then you're forced to deal with basically with what you got. And there may be confounding variables in there. So in this case, they bring that up, which is very good. In addition, we only looked at patients taking hydroxychloroquine and azithromycin. We do not know whether the observed added benefit of zinc sulfate to hydroxychloroquine and azithromycin on mortality would have been seen in patients who took zinc sulfate alone or in combination with just one of those medications. So you can see that they had to deal with what they got there. We also do not have data on the time at which the patients included in the study initiated therapy with hydroxychloroquine, azithromycin, and zinc. So that's really starting to get a little bothersome when you don't know when the medication was actually applied. Those drugs would have been started at the same time as a combination therapy, but the point in clinical disease at which the patients received those medications could have differed between our two groups. That's an important weakness. Finally, the cohorts, which means just a group in which you're changing one variable, for statistically speaking. The cohorts were identified based on medications ordered rather than confirmed administration. So what they're talking about here is that some of the intrinsic limitations that apply to almost all retrospective studies, and it highlights the need to really do the good randomized placebo-controlled forward-looking trials where you actually design the experiment, and it's better to set the parameters firmly in place and don't allow people to mess around with it so they can steer the outcome whichever way they want, depending on how it's going, in the middle of the trial. So that would be what would be preferred in a study. In light of these limitations, this study should not be used to guide clinical practice. And that's often the case with retrospective studies. They give you an indication of what to look for, and guides your intuition towards better experimental design in the trials. And in a battlefield situation, it's good to have any information is better than none. So I appreciate getting this. Rather, our observations support the initiation of future randomized clinical trials investigating zinc sulfate against COVID-19. Exactly, that's what we need. That's what all of us, I think, really want, is to get the good forward-looking trials. But in the meantime, this is what we have. So let's look at what, again, we'll start way back. Often the real information is way, way, way down at the bottom. So another reason to start at the bottom. So let's see, here we go. The last table. The last table tells us, let's move over so you can still see me here. The last table tells us really what we need to know here. Zinc, see on the top here, zinc and no zinc. So it's comparing zinc and no zinc, but in both of those cases you do have the chloroquine and the azithromycin. So the discharged home 77% versus with the zinc versus 68% without the zinc. That's showing that the zinc is really helping. Needed ICU with the zinc 9.2%, without the zinc 15.7%. So it's getting up there, like almost double what the people needed the intensive care unit when they did not have zinc. Now, let's move down here. The needed invasive ventilation. When they had the zinc, it was 33, which is 8%. With no zinc, it was 16.5% needed invasive ventilation. So having zinc dropped the need for invasive ventilation more than half. That's it's a significant, the adjusted 95% confidence interval is 0.48, so it's about 0.5 up to 1.33. Let's see now, does that range fall within the, let's see, it says a half, yeah, half, and then it could be 1.33. So that one is not statistically significant, unfortunately, and because the range goes outside the benefit ratio. Expired in hospice, with the zinc 54, 13% it is. Without the zinc, 22.8%. And this one was statistically significant because the benefits all below 1. And the adjusted p-value here is 0.002. So that's what, 2 in a 1,000. 0.002. 1 over x. Just, oh, yeah, 1 in 500. So that's the odds against this being by chance. So now let's look at this last two rows are extremely important. One is with looking at the groups that eliminated the non-ICU patients after excluding all 9 non-ICU patients, which means they had totally patients that were in the ICU. And what we see in that group is that they're basically the same. With zinc, it was 73.6%. Without zinc, it was 74.4%. So in that case, the zinc didn't help. So if you look at just the ICU patients, the ones that made it into ICU and were very serious, it looks like it was too late at that point to see a benefit from zinc. So the question here becomes, what about if you had it before they went to ICU and you started to do the zinc? And here it really, so that's what the next row, the last row, has, and with the 3 stars, it's for after excluding all the ICU patients. So if you do the opposite, you exclude the ICU patients and just look for the patients where you got them early enough, the question is, can zinc make a difference then? And in this one case, we have that with the zinc, you had expired means died. That 6.9% died, and with no zinc, 13.2% died. So that's basically twice as many. When you didn't have zinc, twice as many people died of those that were treated with the zinc early, and excluding the ICU patients. So what we see is zinc is very important, has has strong effects. Now let's see, is it statistically significant? Both of the numbers are below 1, which means they're helping out. And the range, the entire 95% confidence range is contained there, less than 1. So it's statistically significant, and the adjusted p-value, the probability of it being by chance is again 1 in 500. So very, very significant. And yeah, so that basically sums up the study there. So when you have azithromycin and chloroquine, zinc can make all the difference for if you get it early enough. So it's something that you should start right away, according to this paper. Now, if I make, I'm talking and I have many things to keep balanced in my mind. So I want to make it clear that I'm not making medical recommendations of my own. All of this is coming from the published paper. My purpose here is to just point things out. So let's continue. So I'm basically done with this paper, and let's go to the next paper. When we talk about this, you'll see why I wanted them both discussed together. So the next paper is a paper called, I'll open up here, hydroxychloroquine or chloroquine with or without a macrolide, which a macrolide is an antibiotic such as azithromycin, and there's some other ones, for treatment of COVID-19. A multinational, now they're going outside the country. The previous one was from within the United States. And this paper had 671 hospitals in 6 continents. And somewhere in here they tell you that 65%, I think it was, of the people were from the United States. So it's highly biased in favor of the United States. Yeah, there's a lot of material here. Yeah, so much. I want to do the same that I did with the other one, just to be fair. Start at the bottom, and here we go. Come up and look at the caveats, because again, this is a backward-looking trial, same as the first with retrospective, where you look back at existing data. So there's going to be some caveats for this one as well. Let's look. Okay. Yeah. It says, our study has several, right in the bottom here, our study has several limitations. The association of decreased survival with hydroxychloroquine or chloroquine treatment regimens should be interpreted cautiously. That's something you don't normally pick up in the media, where they'll come out and say, oh, this giant trial was performed and throw the number of people, 64,000 or whatever it is, a large number, and then say, sum it up like it doesn't work. And they're making basically recommendations, which they tell you right in the paper here you shouldn't do. I'll look at their words again. The association, okay, a cause and effect relationship. Okay, the association of decreased survival with hydroxychloroquine or chloroquine treatment regimens should be interpreted cautiously. We cannot exclude the possibility of unmeasured confounding factors. Now, this is something I should have brought up with the last paper, but I'm bringing it up now, and it applies to this paper. And it goes back to, we can refer to the paper that they did on the veterans. Do you remember that one? Where they found that chloroquine didn't help. But I was able to show, and other people were able to show, that there was a profound bias in who was given the chloroquine. And basically what they were doing, and for good reason, I think, was they were giving chloroquine to the sicker groups, knowing that there was a limited supply and that they were saving the big gun treatments for those who really needed it. So the chloroquine group was represented a much sicker group, and it's very difficult to get rid of in any way that preserves information, get rid of the confounding factors, or big factors like that. Well, in this case, 65% of the people come from the United States, and we can expect a very similar, it's in the same time frame, so we would expect a very similar clinical bias, which is actually a good way to treat them, where you give the chloroquine to the sicker people, and so we would expect to have a sicker group. Now, whether they were able to pick it up with their, in this paper there was a very what I thought, compared to the veteran study, a rather limited number of biological markers that they were looking at for sickness, and you know, they didn't look at the blood and all the factors therein. So again, I'm agreeing with them that they need to be very careful with this, and just bring out some other factors. The elephant in the room in this study is basically just that factor that was not mentioned in this factor, and why I'm bringing it up, that there's a treatment bias towards saving the big gun medications for those who would really need them. So that could really bias the paper and confound the results. So here, let's go. Cause and effect relationship between drug therapy and survival should not be inferred. So I did see CNN coming out saying, you know, this study showed that chloroquine did not work, and that sort of thing. And right in the paper, they say a cause and effect relationship between drug therapy and survival should not be inferred. Now I'm going to go on. These data do not apply to the use of any treatment regimen used in the ambulatory, out-of-state, or out-of-hospital setting. Randomized clinical trials will be required before any conclusion can be reached regarding benefit or harm of these agents in COVID-19 patients. So one of the reasons to go to the back of the papers first for these retrospective studies, and go retrospectively to the back, and read is because papers typically don't want to put this stuff right at the beginning, because people might not read it, or I don't know what their motivations are, but it tends to be buried deeply down in the papers for whatever the reason is. And I think it's good to go to the back and read these things first, so we know how to interpret it. So let's look at the results. Okay, I want to bring up another factor here. I have to find it, page 6. Let's go up. Quick search. Is that it? No. Okay. There we go. I want to talk about the dosages, and you'll see why. It's just when you read these papers, you discover things if you look closely enough, and I tend to be just one of those people who really looks closely. Okay, so let's look at the doses here. It says the mean daily dose and duration for the drug regimens were as follows. Chloroquine alone, 765 milligrams. Then it says here, hydroxychloroquine alone, no, it's hydroxychloroquine, not chloroquine. So the first was chloroquine, now hydroxychloroquine, 596 milligrams. Chloroquine with a macrolide, that's like azithromycin, 790 milligrams for 6 to 8 days. So remember that, 790 milligrams, almost 800 for 6 to 8 days. I'll have more to say about that. And I want to say the things I'm going to point out are not messages from me. I'm going to be showing you information from the FDA and from a paper from the Lancet. You know, these are respected information sources. And I got information from another source as well, because I want to double check these things. So none of this is coming from me. I'm just digging it out. So making it easier for other people in the medical practice, so they can hopefully get access to it more easily. And if people spread this around a little bit. So, okay, let's look now at the half-life of Plaquenil, which is hydroxychloroquine sulfate. So here I'm looking at this. This is from the FDA, I believe, and says clinical pharmacology. Following a single oral dose, we have a half-life in the blood of 22.4 days. Now that means that after 22.4, if you take a pill, after 22.4 days, the dose in your blood is down to half. And then another 22 days, it'll be down to a quarter. So this stuff really, like chloroquine, really stays in the body for a long time. It's good if you're treating it for malaria, because you take a pill and it might last you a week or so. Again, I'm just speaking without recommending. So I have another couple of charts on that. So half-life. Here's another discussion. Open this document. Okay. So here's a document it's a paper in the Lancet, and it says, as you can see, the lethal dose of chloroquine in adults is about 5 grams. And here it says the half-life of 20 to 60 days and a tendency to accumulate in metabolically active tissues at higher levels compared to the plasma concentration. So I talked about the plasma level dropping in 22 days. Well, here it says that it concentrates higher in the metabolically active tissues, like maybe the tissues in your lungs that are fighting off the virus. So it gets to higher concentrations there, accumulates. So that's another factor. And here I made a little table showing that the two studies that we just talked about, and we're talking now about the top one here, hydroxychloroquine or chloroquine, with or without macrolide. And I put here that the dose for this one, remember hydroxychloroquine, 790 milligrams with azithromycin as well. So what does that mean in terms of a calculation? Here I have it. The lethal dose is 5 grams, which is 5,000 milligrams, same thing. If you look at that 790 milligrams per day for 7 days, remember it said 6 to 8 days, that's 5,530 milligrams. That starts to make me nervous because it's over the lethal dose, and this drug doesn't dissipate quickly in the body. It slowly goes down. So and you're also including it with another kind of it's not an easy drug, the azithromycin family, and giving it to a sick person whose kidneys may be also affected, and they may not be excreting it even as quickly as an ordinary person would. I just get worried. Now, I'm not a medical doctor, but I want to put that out there and bring it to people's attention. And I look at the death rate. I'll go to the actual results on the paper now. See, I lost the paper, but I'll bring it back up. There we go. So let's go to the results. There. Okay. Slide it down. Okay, so the control group, let's look at mortality, 9.3%. With the chloroquine alone, they doubled they had 16.4%. So there's two things well, there's a lot of things, but I want to just say that, remember, this probably was a sicker group, and that the study people themselves said don't take this as a recommendation for treatments or anything. But that's worrisome right there. Chloroquine with the macrolide, 22%, so it's more than twice. Hydroxychloroquine alone, 18% versus 9%, so it's twice as much. Hydroxychloroquine with azithromycin, 23.8%. So again, more than twice as much. Now this I'm really, it's good, really good to see this, because it's telling me that without the zinc and in high doses, this thing can potentially increase the mortality, and that's something that we really need to look into. So I really would put emphasis on studies where they include zinc in future trials. I hope we get to preserve those ones because we need to get that information out, and it's as you know, it's not good to kill people. So studies where they do high dose without the zinc, yeah, I get worried. They might want to think that through very carefully, especially the doses, before they put too many people under that specific protocol. Yeah, that's probably all I need to say about those two papers. It looks like it would be better to start early with the hydroxychloroquine. Be very careful with the dosage, that you don't overdo it. Also, I said include the zinc. Yeah, that's probably what we need to consider here. Thank you very much.